time, I'm going to go on to the next speaker. And the Kumar doctor had got missed out, so he'll be our next speaker. Dr. Kumar, you could share your video. He's the chairman and MD of the Kumar Doctor Eye Hospital and a versatile surgeon whom we all know, who's going to take us back to an earlier step, reiterate the superiority of phakic IOLs, that they are better than corneal procedures. On to you, Kumar. Are you muted?
Okay. So you can see this?
Yes,
now
we
you can hear me?
Yeah.
Thanks, Chitra, for this opportunity and congratulations on a fantastic show. I think Dr. Praveen made my life a little simpler since he spoke before me, but this was an article as in March 2020, where they've said that the iris claw phakic IOLs have excellent outcomes even in corneal ectasia. So this is what I think he was talking about, and these are giving excellent results. But if you look back at 2008, surprisingly, long-term use of the artificial lens said that there was endothelial cell loss. So it was not doing so well then because the lens design has changed, everything is done. We have used varices phakic IOLs many years back, and they gave excellent results in high myopia. So this was documented then. So these are the two phakic IOLs which are the most popular ones which are used. One is the iris clip IOL and the star, or any of the phakic IOLs which are posterior, placed in front of our normal natural lens. There was another article on phakic IOLs which said that this did well, but as far as the toricity was concerned, it was not very stable, and that's the reason why they tend to rotate. And then came the perfection of sizing. Sizing was the most important thing where the mistake was being done. So here comes the next article about why phakic IOLs, and this was saying that in severe myopia, it gave much better predictable visual outcome than laser refractive surgery. So this was one more thing that was produced out in 2000, and this was about in 2016. Coming to the American Academy, Stephen Lane believes that phakic IOLs is the way to go, and this is not a very old article. And he said that this is a much safer prospective procedure. The main thing being that LASIK is all about subtraction. We know this, right? So we are removing tissue. While phakic IOLs do not carry inherent problems of corneal surgery. So we are adding a lens, okay? So we are not disturbing the other optical system at all. So we are not disturbing the cornea, we're not disturbing the natural lens, and we are adding a lens. So actually it aids and it really helps our patients. So this was again a report by Stephen Lane as far as the American Academy was concerned. Then came the posterior chamber phakic IOLs, and here they said the treatment was much better for high myopia. Initially, if you remember, we used to do phakic IOLs for very high myopia of more than -12, 13, and 14. Now that came down to 10, and then it further came down to, and some of us use phakic IOLs for more than -8. And of course, we know that the biggest advantage of phakic IOL is the reversibility, immediate correction, which we know, stability, and relative simplicity. A lot of techniques of phakic IOLs have changed over time. Previously, for example, in star ICL, I used to use methyl cellulose, and now the new thing that we are doing is we can put the ICL just under irrigation, and we really don't need to put pilocarpine to constrict the pupil, and this itself made the stability, and no need to remove methyl cellulose, no fear of the IOP going up, etc. Again, phakic IOL in tough cases, as rightly pointed out by Dr. Praveen Krishnan, that it can be used in patients who undergone C3R. So I've used this in patients who had intacs with C3R. The biggest advantage of intacs is that it centralizes the cone. Once it centralizes the cone, we can go ahead and do the phakic IOL, of course, knowing that the chamber is deep enough to take a phakic IOL, and this gave excellent results. You have to wait for the X amount of time, and that would give very good results. There was another study by Nasir which said about phakic IOLs, and this was almost 69 eyes for 46 patients, and ranging from as little as myopia of 3 to 25. And this gave excellent results. So myopia as little as 3 also was attempted with a phakic IOL at that time and gave excellent results. Coming to phakic IOLs and surface treatment. Now we all know, as rightly mentioned by Dr. Rajesh Sinha, that surface treatments can lead to haze. Phakic IOLs is a lenticular path, we know this. no issue of knowing a vitamin D, no question of post-op period of recovery, no issue of faster visual recovery, no question of wound healing, no question of apoptosis. So all that is taken care of when it comes to phakic IOLs and surface treatment. So comparatively, we know that surface treatments now with the new smart pulse treatment, the recovery is much faster compared to the older 4 days. Now it's almost 2 days. The pain is almost gone. But it has an element of a question mark in some patients. And of course, as mentioned, that ultraviolet light and exposure to UV light and the holiday haze can also happen in this case, which nothing of this type will happen in phakic IOLs. Some studies had talked of rotation of IOLs, the phakic IOLs, and that's why the most important thing that has come in now is about sizing. So the sizing now is much better. We have a big choice of Indian phakic IOLs. The Star ICLs are also available. The two companies from India, the IOCare and the Biotech, are also available. Another study from Academy where you will be surprised, ever since phakic IOLs have become FDA approved, and there was one article which mentioned that it devoted almost 12 out of 45 chapters to phakic IOLs. But of course, this was in 2008. That is when phakic IOLs actually picked up 2007 edition, where textbooks started writing more about phakic IOLs after it got FDA approval, and so many chapters were mentioned about it. This is as past as Academy 2020. There is a comparison between toric Collamer IOL and a toric artifact phakic IOL and visual outcomes. And they have shown promising results in terms of safety, efficacy, predictability, and correction of myopic astigmatism. So phakic IOLs, we know now can even do toric corrections. They have been doing toric corrections, but even the iris claw phakic IOL can do a toric correction. And this has been shown in a paired study, identical. These lenses were clinically superior to any other lens that was found. This is as past as the American Academy study. So this is the toric phakic IOL that is now also available in the market. We also know that the Star toric IOL is also available in the market. So lots of Indian companies are nowadays making phakic IOLs too, but not enough published data is found on this as far as my knowledge goes, but of course all of you can add to this. So what is the advantage that I find in a summary? No cutting of cornea, so all the benefits of no striae, micro striae, macro striae, no free caps, all that is gone. No upside down caps, everything is gone. The question of dryness is sorted out completely. No ectasia, that's one biggest benefit is there, so you're not touching the cornea at all. And no issue of quality. You know, some of our patients do have 6/6 vision. They've undergone perfect smile, they've undergone perfect LASIK, and yet some of them do complain that they're not very happy with the quality of vision. So here, the biggest advantage is completely reversible. Up till now, of course, I have explanted one phakic IOL, which was the first design of the Star. Now it's the fourth edition where the central hole has appeared. And that time it was much thicker, much bigger in size, and we had to explant it because of glaucoma. So the advantage in phakic IOL, I feel, is reversible. Cost is an issue if you get the phakic IOLs from abroad, but Indian phakic IOLs, you know that the cost is not that much of an issue. And application of these IOLs after cross-linking, as likely mentioned by Dr. Praveen. So replacing LASIK, I think for thinner corneas, now our cutoff is much better, thinner corneas. So if your cornea is thin and your anterior chamber is good enough, higher refractive errors for more than -8. Complex cases, if you do intacts with C3R, and if your cone is central, you can still go ahead and put a phakic IOL. With the central hole, all the other complications have actually gone. So in summary, yes, this option is quite possible and quite available for our patients.
Thank you very much, Kumar. You are so eloquent. I have 2-3 rapid questions for you. Would you sell your eczema and shift to phakic IOLs altogether? Number one. Number two is, do we have studies? We have said that after central flow coming in, the incidence of cataract has totally gone. And the third question is, with the lens rise, which is being much discussed now, do you think there will be vaulting, increased vaulting of phakic IOLs later?
So the first question is, I will not sell my eczema. The second question is about vaulting. And I said, actually, the central flow is more for glaucoma and not for cataract. So the prevention of glaucoma, and because I think Gaurav started this technique of putting irrigation, not putting methylcellulose at all in the anterior chamber. So the question of your central flow getting blocked by methylcellulose is completely gone. And that's the biggest benefit that we get. So you can inject the ICL just under saline, and you don't really need methylcellulose. As far as vaulting is concerned, yes, we have to look at the vault post-operatively in all the cases. But now I think with better size understanding, with electronic calipers, with OpScan, and all those comparison data, the sizing is a little better. So now, in fact, last few months or few years, whatever we are seeing, the sizing is really sorted out. Once in a while, you may get a high vault, but otherwise, it's not leading to an explantation. So that's not where we have reached. All of you may have more data, but this is what I have found in my clinical data.
Kumar, regarding your question about comparing the Indian lenses with the Visian, we recently did a study, an in-depth study, and it is in print now in the JRS. It's been accepted in the JRS, and we found that there is not much of difference. And even the Indian lenses with Biotech, they perform very well.
So you compared with Biotech or IOCare?
Biotech. This was a comparative study with Biotech.
I've done a comparative study with RIL of Appasamy and ICL, and most of the parameters were almost the same. Only the MTF was better. MTF on eye trace was better in ICL. Rest of the things were absolutely comparable.
Dr. Praveen, could you introduce the next speaker? Thanks, Kumar.